We want to welcome you and thank you and enjoy the presentation.
Thank you, Francis, very much. I also want to thank Cambridge Public Library for hosting us. We really appreciate it. And for those of you in the audience, thank you for coming out on a rainy night. And for those of you at home, thank you for tuning in. And for those of you watching this at a later date, thank you for your interest. So the topic for tonight, as you can see, is the intersection of substance use and psychosis. Either one of these entities is terrifying. And when they happen together, it's terrifying multiplied. And I think many of us have experienced this. We certainly have in our family. So tonight, we have an expert on this topic, Dr. Julie McCarthy. She is a psychologist, assistant professor at the Harvard Medical School, and she works in the Division of Psychotic Disorders at McLean Hospital. So without further ado, thank you, Dr. McCarthy, for joining us, and please introduce yourself at maybe greater length than I did, and then we'll hear your presentation, and then she and I will sit up front and take your questions, and that's how the show is going to run. So welcome.
Thank you so much, Dr. Parker. So hi, everyone. I'm Julie McCarthy, and as Dr. Parker had mentioned, I'm at McLean Hospital, and so I think for me, I'm so excited to be here. I've worked with referring people to NAMI and have had the pleasure of working with people who have come from NAMI in the past, and so this is my first opportunity to speak with this group. And a lot of the work that I do as a researcher and as a clinician has really stemmed from a lot of support that I've gotten from the National Institutes of Health, Harvard Medical School, and generous philanthropy support. And so today, I do have a few disclosures. I have been a consultant to custom learning designs and have collaborated with We the Village. So importantly, also, I have loved ones who have experienced themselves psychosis and/or substance use and related mental health experiences too, and some of whom have received support at McLean as well. And that being said, in the past, people in my personal and professional life had asked me at different times, what do I do when I have a loved one who needs help? But they don't rise to the level of needing inpatient hospitalization. They're not necessarily on board for getting the help that's been recommended to them. What do we do? At the time, I didn't have great answers, to be fully honest. And fortunately, since then, I've really thought about, sought training, and learned from many different families that I've worked with what skills are helpful, what skills we can use as family members and as friends and as supporters to the people in our lives who need mental health support most. And I'm excited to share one of those approaches with you all today in a bit. So first, we're going to talk a little bit about substance use patterns and psychosis and what the connection is there, and importantly, how families can help. And then we'll save plenty of time at the end for Q&A. All right, so first up, why do we care about substance use? I mean, it might seem quite obvious to this group. And across the country, there's over 46 million people ages 12 and older in the United States who report having a substance use disorder at some point in the past year. This is not just using substances, it's rising to the level of having a clinically significant diagnosis. And there are, beyond that, most common substances being endorsed are alcohol use disorder, marijuana use, and painkiller use, among the other substances. Slightly more recent data from the same large national data set had showed that the one substance category that increased the most by 3 million people was marijuana use disorder in just the span of 2 years. And that rapid increase may be due to things like legalization or other changes, but this increase is something to pay attention to. So a little under a quarter of people who have a substance use disorder actually are receiving substance use treatment. This graph is showing folks who are not getting treatment for substance use disorder and what's going on in this group. So this group is adolescents, and the vast majority, about over 96% of people in that category aren't getting treatment because they don't feel like they need treatment. There are a smaller number of people who feel like they need treatment but may not seek it out, and then an even smaller proportion of people who actually try to get help and are unable to successfully connect with care. For adults, it's a similar story. Most people who aren't in treatment don't think they need it, so that might be because they don't know what the definition of a substance use disorder is, perhaps, in terms of warranting additional support, or they may recognize that there is a problem, but they don't want to seek professional care for it. And there's a lot that can be done on one's own, too. And also, people may or may not have insight at all that there's a problem. So it could be for a variety of reasons. I think one of the things that often comes up for families is this idea, when we have loved ones who are experiencing substance use issues, that it seems like things like cannabis are, quote, everywhere. And also, that's not always the case. So there's a large national study on youth, actually, and substance use patterns. And when people ask high schoolers how often they're using cannabis, it's actually less than half the people who are 12th graders even who are reporting using cannabis. It's actually more like 40% or so ever since the mid to late 90s. For people who are even younger, it's an even lower rate. And this is just endorsing using at least once sometime in the past year. When you look at daily use, those numbers go down even further. So it's more like 7% or so are actually using daily who are seniors in high school, and even less for the lower grades. I bring this up because sometimes there's this perception, whether it be for ourselves or our family members, that everyone's using it. And it's an overestimation often, and they've done these studies in college students as well, where people think a lot of the people around them are using a substance more than they really are. And why this is important is because when we think more people are using a substance and we think that there's a lower perceived risk for that substance, that belief is associated with using the substance more. And so it's something to be aware of, kind of what the actual numbers kind of look like. All right, so how does this relate to psychosis? Because that's why we're here tonight too. So about half the people who come in with psychosis have some lifetime history of a substance use problem. For cannabis specifically, when folks come in for their first episode of psychosis, there's 20% of people who say they have never even used it at all. So it's kind of a non-issue for a subset of those folks. For about 30%, they stop using cannabis altogether. One diagnosis or one trip to the hospital, that's it for them. And then that leaves just over half the people who continue to have some sort of sporadic or quite regular use of cannabis. So this is still a pretty relevant issue for a lot of the people who might be coming in the door. And why this is an issue is because on the front end, cannabis is associated with increasing the risk of developing psychosis. It's associated with early onset for psychosis. And there can be just pure frequency rates, more people reporting that they're using cannabis even before they have full-blown psychosis, kind of believing delusions or hearing voices or seeing things that aren't there, but more attenuated symptoms even at that stage. People are reporting using cannabis more. And then when people are using cannabis, sometimes it seems like, oh, maybe the psychosis is just happening because they smoked a lot of weed, and it seems just contained to using that substance, and so that might be deemed substance-induced psychosis. And so sometimes the question comes up, well, are we going to see another episode of psychosis again? What's going to happen in the future? And about 25% of people who do have a substance-induced psychosis experience do go on to have schizophrenia more long-term. So the association or the risk is certainly there. It's not just for cannabis, though. So yes, the majority of people who do go from a substance-induced psychosis disorder to actually having schizophrenia is highest for cannabis, but also hallucinogens and amphetamines or stimulants are also part of this picture of increasing risk. And sometimes it can feel frustrating, whether it be for family members, clients themselves, or clinicians to say, well, how do I know? Why don't I know what the diagnosis is now or today? And part of the reason why that is because it takes 6 months to get a diagnosis of schizophrenia, to see what happens over that course of time. So it's not uncommon for diagnoses to change too, which I know is not always the most, clear kind of picture to have. There's a lot of unknowns there, but it is part of the process. Also, cannabis in particular and other substances are associated with increased risk for relapse as well, and worsening of not just the psychotic symptoms, but also functioning difficulties as well. So we might think, well, with all of these potential issues that our loved ones or maybe ourselves and our own lived experience, if you have that, might be having as a result of using substances, why keep using them? Well, there are a lot of reasons that make actually a lot of sense for people to make that choice in the moment. Some of those reasons or motives for using include coping with negative experiences, maybe if they're feeling very depressed, or maybe if they have a lot of anxiety, or maybe they just want to feel good, have a buzz, have a high, or it's a social thing. This is how they connect with people, and who doesn't want to connect with other people? Or maybe there's actually not a lot going on and it's out of boredom. That being said, these are very short-term rewards that reinforce the use, and sometimes it makes it hard to compete with the longer negative consequences that we just discussed. That being said, it gives us a framework to understand why our loved ones may use substances even if we don't agree with it. And there are other ways that we can help them build up other avenues to meet these same needs without substances too. So let's say we do get a loved one in the place where they're getting treatment, or maybe they've been in treatment for a while. What does that look like? How does that help substance use and psychosis? And there was a recent meta-analysis about just this question. And they looked at a lot of different approaches, a lot of different studies for individuals with psychosis and substance use, some family interventions as well. And they found the most data for a mixture of something called motivational interviewing, which you may have heard about before, kind of a style of talking to someone where you're not telling them what to do, you're helping them kind of come to their own conclusions and motivating change for them to move forward in their own direction, and CBT, or cognitive behavioral therapy, looking at changing the patterns of thoughts, feelings, and behaviors that we have. Unfortunately, if you look at this long list, and I don't expect you to read all of it, the take-home point is that most of these studies did not find a significant difference or a significant benefit of using that treatment under study to reduce substance use compared to not having any treatment at all or another control. There have been some studies that have shown some shorter-term gains. However, what this shows us is that we have a lot of work to do. There's not necessarily one established treatment that works really well for people who have both psychosis and substance use. There are treatments that work for both of those things separately. So it doesn't mean that there's nothing we can do. It means that we might need to think about what the timeline might look like, or what combination of tools we might put together that might work well for either ourselves or our loved ones. So the other question that this makes me think about is substance use reduction the be-all and end-all of this conversation? As part of the research that I've done, we've asked people, what's your goal in treatment? Or what's your loved one's treatment goals? I'm pretty sure, and I'll have to double check the data again, but almost no one has said reducing substance use is their treatment goal. Like, that's not what they're coming in for. They're coming in for other things, like maybe it's, I want to feel better, I don't want to feel as depressed, I want to be able to think more clearly, I want to finish school, have a relationship, move out of my parents' house, things that many people would want. So there's been a recent move in the literature, and I think in a lot of circles, about this idea of harm reduction. So thinking about, okay, if someone's going to use a substance, how can they do so in a way that's going to result in the fewest consequences as possible? So there was a recent paper that came out about this, and they came up with certain recommendations. Yes, this paper is geared toward people who are in the adolescent phase, and also I think their recommendations apply really well to most people. So the take-home points here are, one, to minimize the use of THC, which is the psychoactive property of cannabis that gives you that traditional high feeling. And if you are going to use a cannabis product, try to opt for a CBD or cannabidiol, which some research studies which suggest could actually have neuroprotective properties. The jury's still out in terms of actually being able to recommend that for people with psychosis and who have substance use. So second would be to avoid high potency. Over the past number of decades, potency for cannabis has skyrocketed, especially if you're talking about synthetics like shatter, butter, things like that. So if you can avoid the higher potency, that's a way to reduce harm. The third is to be cautious if you're using oral roots of cannabis like edibles, especially if they're homemade, because ingesting cannabis through an edible can lead to longer lasting effects than perhaps just smoking or vaping. And then even though it seems like a healthier alternative to combustible smoking of cannabis, the variability in the potency or the product itself can be much higher in something that's especially homemade. And then number 4 is to reduce the frequency. So this is something that a lot of us might be able to relate to for any type of change. Do we go from 0 to 60 with doing everything differently at once? Often not. Some people are able to do that, and more power to them. So even if it's reducing how many times someone's smoking in a day or how many days in a week people are using, any type of reduction is movement in the right direction. And some people may say that they actually never want to quit at all. But we'll talk a little bit more about that in a moment. So in summary for this section, cannabis does not cause psychosis. It's got a lot of associations with increasing risk for developing psychosis and relapse, but it does not cause psychosis, because if it did, everyone who smoked cannabis would probably be experiencing psychosis, and that's not the case to the best of my knowledge. 2, we know that cannabis is not the only substance to keep our eye on. It's one of several substances that can be involved in this risk for psychosis. 3, there's no gold standard treatment. So just like with medication, yes, treatments can be helpful. No, they don't work for everyone. And so being able to be open to trying things and also not expecting it to solve everything all at once can help temper expectations. And also we can encourage folks to start slow and go low. Like if they're on the younger side, if they can delay when they start using cannabis, that's a win. If they can start lower with frequency and potency, that's also a win. Okay, so now we're going to switch gears and talk a little bit more about how families can help. So one way to start to think about this is, what do these conversations already look like among family members? So we did some pilot studies to get at this question, and we were able to get a small number of people who had psychosis and substance use and their personal family member, which is harder than I had originally thought, because sometimes people don't always want to be part of the same conversations or same clinical experience or research studies. That being said, for the people who we did talk to, 50% of folks who were in these parent-adult-child dyads disagreed on not even how much substances were being used, but which drug at all would potentially be or was the problematic substance for that person. So they weren't even on the same page about whether it's alcohol or cannabis or opioids or something else. However, the dyads, or groups of people who were in agreement, did have better communication between the two of them, and these were all rated independently. They were not in the same study sessions. They reported better general relationship happiness with their family and more family involvement in treatment. For the people who disagreed or had discrepant ratings with their family members, 80% wanted less family involvement in treatment. So there's not necessarily a directional conclusion here about which part of this is driving the other. However, it does show us, gosh, there's an opportunity for how we can improve our relationships with our loved ones, our communication with our loved ones, to then give us more opportunity to at least get a little bit more on the same page. So one thing that I found surprising at first when I was doing this work was that when we asked folks with psychosis, have you ever tried to cut down or quit using alcohol cannabis, nicotine. 100% of people said that they had actually already tried or successfully reduced their substance use. I was surprised. I think family members would be surprised as well, because often the assumption is this is a problem, they're not doing anything about it because they're still using it. When in reality, there actually might be a lot more movement going on there than we might realize. And there could be reasons why we don't know that. Maybe because they're afraid of disappointing you if it doesn't go the way they want or you want, or maybe they're embarrassed that they have this problem in the first place, or who knows what it might be. Sometimes we do have folks who do tell their family members that they're experiencing or they're experimenting with a sobriety kind of week or couple of weeks. And anyway, I share this to give people hope that just because you don't see it doesn't mean progress isn't happening necessarily. The other part of this is that we might not know about this at first glance, because when we ask people how much they feel comfortable talking to their treatment team or family, 83% of people said that they do feel comfortable talking to their treatment team, but only 42% said that they felt comfortable talking to their family about substances. And some of the reasons that came up were things like fear of negative judgment, or it could be, some of what the literature also says is being concerned that their family wouldn't be able to handle what they had to say, and also that sometimes people just wanted to protect their family members. They didn't want to burden them with additional worries, and so they would keep this information to themselves, not just about substance use, but about psychosis symptoms as well. So I think that even though the conversations aren't happening, it doesn't necessarily mean that there's a bad relationship or anything like that. It also could be coming from a place of trying to protect and preserve the family relationship as well. All right, so that being said, there are people who do reduce and cut down using substances, and there are reasons why they do that. Some of the reasons are health, their personal well-being, whether that's physical, mental, income, family, the things that they build in their lives that they don't want to lose. And this is important because sometimes we think, oh gosh, if they just quit substances or if they just took that medication for psychosis, then they would be able to achieve these things. Sometimes people put these supports or resources in place, and that becomes the motivation to manage symptoms, to manage substance use, because now there's something to work for. Something is at stake. And so often it's a bi-directional relationship, and so it's okay for people to still make progress even if you may not see as much movement with the substance piece at the same time, because chances are if you improve one of these areas, the other will improve as well. So another element of this certainly is formal involvement or communication between family members and treatment teams if that person is in treatment. Unfortunately, that doesn't always happen. A lot of times we work with family members who have adult children, or actually all of the people that I've worked with have adult children, or have adult siblings or spouses. And that means that they have the choice, unless they have a legal guardian, to choose whether or not they sign a release of information to have their clinicians be able to talk with other people in their lives. So what do families do if they do not have access to those types of clinical supports? There are support groups, things like NAMI that can be really helpful for people. And sometimes people are also looking for additional skills. So one of those approaches is CRAFT, or Community Reinforcement and Family Training. And the goal of this originally was to help people get into treatment. But a lot of people we work with already have a loved one in treatment. And so it's also to help support people who are at any stage of their recovery. And when family members were trained in CRAFT skills, 7 out of 10 people were able to help get a loved one in treatment for substance use, at least for the very first time. And when folks already have a loved one who's engaged in treatment, you're already ahead of the game. So what does CRAFT actually include? Some of you may know about this. For some of you, this may be new. So one, it involves building motivation for you as a family member to think about your role and what you can do in this relationship with a loved one, versus thinking about trying to fix that person. Another is thinking about self-care and goal setting. thinking about how we can model taking care of ourselves the way we might want our loved ones to take care of them. And then the most helpful topic that people said came out of CRAFT across the sessions that we worked with was communication. And it really is the foundation of a lot of the other skills that we work on as well. We also talk about a functional analysis, or understanding the why people use substances and what we could potentially use as a roadmap for replacing substances as well. We think about positive reinforcement, how we can encourage healthy behaviors that don't involve substances, and also thinking about healthy boundaries and allowing for natural consequences so that we don't have to feel like we're fully responsible for changing a loved one's path with substance use or treatment, that we can actually empower them to make their own decisions, and we can help support them get to the goals that they care about. And we also talk about ways to think about approachable conversations to discuss treatment, or offering different ideas to that person to help them reach their goals, and then problem solving along the way. So I'm going to talk on a couple of points that tend to be most relevant for the families that we've worked with. So one is that timing is everything for a general communication skill. Sometimes we go in very strong with our own agendas, and we may not have a lot of opportunities to talk to our loved ones, especially if they don't live with us, or even if they do, it's like those 5 minutes when they're out of their room, it's like, oh, I gotta get them now. And so instead of thinking about just what works for us, we can think about when is a good time for us in our own mood and not feeling rushed, and also when is our loved one at their best, so that we can, to the best of our ability, line those things up and also ensure that everyone's sober. So we're here to talk about substance use and psychosis. So it can be very tempting to say, oh, I see them using, alcohol or cannabis or something else. Now's the time to nip this in the bud and have this conversation so it doesn't become more of a bigger thing. And you could have the best conversation in the world in that moment, and the next day the person may not remember it. So we really encourage folks, to really think about when they want to have that conversation. And if you want to have a meaningful one, try to choose it at a time when everyone's sober. All right, some of the specific communication skills that we go over are be brief, so we don't overwhelm people. Be positive, because the focus is often on what's not going well or what could be better. Be specific and clear, because sometimes we use vague terms or just confusing terms that may mean something else to another person, like, oh, I wish you would work on your treatment more. Well, what part of that are you referring to? How can you get more objective and specific and label your feelings? A very classic, I feel statement for communication. The last three are especially useful if you ever run into a loved one bringing up their defenses in a conversation. So offering an understanding statement can be as explicit as, I understand why you would feel this way, or you don't have to use the word understand. You could say, yep, if I were in your shoes, the last thing I would want to hear is, mom telling me what to do. I got it. You can also potentially run into situations where your loved one says, you don't get it, you don't understand, you don't know what you're talking about. And the urge may be there to pick up that rope, play tug of war, and say, no, I do understand, I get it. I've been there before, I know what it's like. Or even if you don't, you may think you know. And instead of doing that, that's our cue to drop the rope, and we can say, you're right, I don't know. I'd like to. What would be important for me to know? People don't usually argue with being right. So it's a way to change the dynamic in the conversation a little bit and to be curious so that we give them a chance to tell us something a little bit different. And then this is also a chance to highlight what's important to the other person, to find common ground in what they're saying, because at the end of the day, usually families and their loved ones want the same things. To live a life that they enjoy, maybe to be independent if they can be, and to make the most of the situation that we've all been given. So the next skill is to accept partial responsibility. This in no way is saying that you should take responsibility for your loved one's choice to use substances, their choice to take medication or not, their choice to talk to a therapist or not. This is more about loved ones sometimes feeling like they're being a little bit attacked or maybe ganged up on sometimes, or feeling like they're the ones in the wrong for whatever reason. And there's a natural power dynamic that comes up in families often, certainly between parents and children, even if those children are adults. And so to come at conversations with a more collaborative approach, taking ownership of what we've said or how we've said it, or what we have done or not done, models responsibility and shows our own vulnerabilities so that we are clear that, we're all human, we're not perfect. And so one example of this might be to say, hey, I realized that the help I was offering you wasn't really the help that you were looking for. I'm sorry, and I'm going to do better to try to listen more to what would actually be helpful to you. And we may or may not get the same behavior back. However, it can set the stage for showing that it's okay to admit that maybe we can take responsibility for things. So the last specific communication skill is offer to help. This can be very specific, like, oh, I'd love to help you make that appointment, or a broad offer to help. Hey, if you want to talk about that thing that happened with your friends, let me know. I'm here if you need me. And an important part of this that I emphasize with folks is asking permission to offer help before giving it. For many of us, we have the natural tendency to want to problem solve and fix, oftentimes because we have really good solutions, really great ideas, and if they just did those things, then wouldn't everything be better? And I don't know about you, I don't like to be told what to do. None of my family members like to be told what to do. And so, especially if someone's been in an inpatient hospitalization, they have been told what to do a whole heck of a lot. And oftentimes people feel very out of control because they're not in charge, and that can be a very scary place. And so by even asking permission, like, hey, do you have a minute before you dive into a conversation? Or, hey, could I share an idea? Or could I offer a suggestion? Gives them the power and the respect to make a choice, so long as it's not a life or death situation, to then think about whether or not they want to accept your help. If they say, yeah, go for it, you can share all of your good advice. And if they say, no, we don't need to push, we can respect that and say, okay, let me know if you want to talk, I'm here if you need me. You can keep that door open. And what this does is it changes that back and forth that sometimes happens, and at least reduces some of the stress in those conversations. And at the end of the day, I remember one of the first family members that I worked with, she said that what she wanted was a better relationship with her loved one. It really wasn't just about substance use or getting into treatment or where they were living or anything like that. It was the quality of the relationship. And so these skills are things that you can use in any conversation. And sometimes we talk with families about trying to have conversations where they're not big conversations, so that you can build the relationship so that it can withstand the tougher ones that will come up. And some of the milestone conversations that we guide families through are what's important to my loved one, how do they feel about treatment, what do they think about their substance use, what are the good things that they think about substance use and any challenges that might come up, and then asking permission to offer any ideas to help them reach their goals. So just like I do in my clinical work, I talk with families about how they can help their loved one reach their loved one's goals. All right, what we've learned from research is that this type of approach decreases family members' depression. Same with anxiety, it also improves relationship happiness with their loved one. And when we've compared craft that we've adapted for early psychosis compared to not getting it or treatment as usual, depression was the strongest effect that we found for families improving their own well-being. And one family member had said, I wanted to learn more about what is effective, what does work, how to look at it differently, especially how to communicate without using threats or ultimatums or just negative thinking. And I was hoping to learn how to communicate all of that better, and I feel like I did. So we've learned that this approach is definitely feasible and acceptable. We can do it online, we could do it in person, potentially, just as easily if you're willing to drive. And then it improves family well-being, which is so important, because the more that we can take care of ourselves as family members, the better we can continue to care for our loved ones. And somebody had also said that this is the single most helpful thing that they had done. If you haven't had a chance to learn about this type of craft approach, we have a bunch of different webinars online through our Crafting Families Support Family Webinar series. And these are some of the top topics that people have already viewed online or have attended in person. And we're still in the process of uploading some of our 2025 videos. If you're interested in checking those out, this is on YouTube at the Crafting Support Project channel. So you can feel free to take a screenshot if you like. This presentation is being recorded if you want to check this out later. And if you're interested in one-on-one coaching, we actually have a new program at McLean that we started this summer, the Crafting Family Support Program, which is open to all Massachusetts families. We offer up to 8 to 10, maximum of 12 one-on-one sessions with me or someone who's part of our team. And this is done on Zoom, or it could potentially be done in person. And it's insurance-based. It was really important to the families that we worked with, myself and our hospital, to offer something that was accessible as possible to people. And if you're interested, feel free to shoot me an email at jmccarthy@mclean.harvard.edu. All right, and I just wanted to thank everyone who helped make this possible, thank NAMI for having me, and thank all of you for your attention.
Okay, now thank you so much. Can I call you Julie?
Yes,
okay.
please do.
Thank you so much. Have a seat over here, and we have some questions from the audience. And this should work for you. This should work for me. Can you hear us okay in the back? Great. So you gave us a lot of food for thought, both kind of the general context and also some specific things that we could do. For you that are here in the audience, Francis will come around. If you have a question, feel free to write it and he'll bring it up. And we do have some questions here. They're a little kind of random in terms of their order, but I think that'll be okay. Just kind of on the general, with the substances, I didn't see narcotics on your list. What is the relationship between people who may be addicted to any narcotic, morphine, Oxycontin, codeine? How does that relate to psychosis and treatment?
That's such a great question. I think a lot of the conversation around substances is around opioids and different narcotics. And when you look at the rates of how frequently people are using those types of substances among people who do have psychosis, it's actually quite low. So usually we see certainly nicotine, alcohol, cannabis, then cocaine usually, and then other narcotics like opioids are a little bit further down. So first of all, it doesn't come up as frequently. That being said, it does occur. And we've definitely worked with family members who have had loved ones using opioids as well. And so I think that I don't think that there's necessarily something specific about psychosis with the opioids that we would change in terms of our approach necessarily with identifying or engaging in treatment, but we would think about, from the substance use field, what is needed for treating opioid use disorder, and certainly think about any medications that might be relevant there that wouldn't be the case for other types of substances perhaps, so that we would want to treat the elements of the substance at hand, because every substance is different, and also thinking about that there is going to be likely a similar type of risk in terms of exacerbating the picture with psychosis, even if it's not directly increasing hallucinations or delusions. Having a substance on board, like other narcotics, will likely impair cognitive functioning, that we know, or difficulty with keeping a job or housing or relationships, and all of those things can either be strengths or supports for someone who is getting treatment or trying to live their life with psychosis, or they can become sources of stress. So,
Great,
yeah.
Great, thank you. You talked a bit about individual therapy and family involvement. So can you just give us a little more flavor about the benefits and the pros and cons of both, and kind of how you approach a patient and their family?
Sure. I was just in a meeting talking about this very issue with folks who are interested in trying to figure out more and effective ways of incorporating families into the discussion. So I think that a lot of times, especially because people are often adults getting care for psychosis, they value their privacy, and when we think about what the recommended treatment is for especially early psychosis, it's coordinated specialty care. And if people are less familiar with what that means, it's a constellation of services all in one spot. So it's kind of like one-stop shopping with a therapist, someone to prescribe medication, someone to help with case management. And if you're lucky, you'll also get maybe a person with lived experience as a peer navigator and a family peer navigator too, and groups as well. So in that context, when people look at the extent to which family is, quote, involved, at the very most basic definition of that, whether it's attending one appointment or at least having some communication with the team, in some studies, the rates are as high as, like 95% of cases, maybe having some degree of family involvement. In other studies, that number is much lower. And I think that it also points to the fact that it may not just be about family involvement, yes, no, but the quality of that involvement as well. And so right now, some of the options that are recommended from a first episode psychosis standpoint especially would be having what's called family psychoeducation. A lot of you in the room may already have a lot of education or background about what psychosis is or what substance use is about, but it's part of making sure that people understand what their loved one is experiencing, because for many people, this is the first time that they may be hearing some of these terms or hearing the word schizophrenia or schizoaffective disorder. So I think that giving people some language, some expectations can help. And then I think a lot of what the families that I work with tend to find helpful is figuring out how to problem solve, what decisions family members can make to help support their loved ones. Questions about medication sometimes come up. And so to some degree, what we also recommend is regular coordination with the family. If it's just an update, we're not saying we need to clue in the family on everything that's going on in an individual therapy session, like that can be private. And also, sometimes, especially if the client is living with a family member, it makes a lot of sense and kind of helps the logistics if everyone can be on the same page about what's happening, who they're meeting with, or maybe if there are any issues and how we can improve them. So even if it's having like a family meeting, not even family therapy, once a month or so, that's ideal. I know that doesn't always happen. And so the other option that we give to people who are in treatment for psychosis is, well, what level of involvement would you like your family member to have? I think it's helpful if we create the culture of, hey, this is a family experience, this is a family treatment approach, and also if someone's hesitant about having family involved, we can say, we can explore that. What are your reservations? What would you want them to know?
Let me ask a related question, and I realized that I was remiss in not reminding everyone what NAMI is, because I just made an assumption that everyone knows, but NAMI is National Alliance on Mental Illness, and we're a volunteer organization, and we are not professionals, and we get minimal training, and then we run family support groups, and we run family to family where we're teaching people about mental illness, including psychosis. But kind of what's your view of the role of us volunteers along with you all professionals?
Oh, that's such a great question. I refer every family member that I work with in our resource list to NAMI support groups or family to family. And for folks who may not know about family to family, it's, from what I understand, correct me if I'm wrong, around an 8-session program to help families with all types of mental health concerns, not just substance use or psychosis, think about how they can support their loved one with their mental health experiences.
Right. So let's see if we can get through some of these other questions. Let's see. Should people with schizophrenia be prescribed stimulant medications?
Ooh, great question. Full disclosure, I'm a clinical psychologist. I'm not a psychiatrist, so I do not prescribe medications. So I would defer to anyone's personal prescriber for what might make the most sense for your particular situation. In general, though, one of our colleagues at McLean actually had published a couple of papers on very large data sets of people who experienced psychosis and were prescribed different stimulants. And she did find an association that when people were prescribed certain stimulants, there was an increased association with having a psychotic disorder diagnosis. And these were, I think, medical claim records. So, it wasn't really a question, that was the diagnosis. And so I think that there are also people who have ADHD or might be in the market for wanting some supports that stimulants are traditionally able to offer. So I think it can be a discussion with one's provider about what makes the most sense. And yes, there is some support suggesting that there could be either a risk associated with using stimulants, or it could be a shared underlying concern between those folks who are more likely to get stimulant prescriptions and who also develop psychosis.
Great, thank you. Here's one: how to approach substance use in a patient who is actively hallucinating, or can you, or should you?
Good question. So I think some of these answers will be in it depends, certainly on the nature of hallucinations. Like, I had definitely talked with people who said that they would be hallucinating, hearing voices, and still holding down a job. And, for someone like that, if they said that they were also using substances, I think I would approach talking about substances with them the way I would approach talking to substances with you if you were using them. So I think just because someone's hallucinating doesn't necessarily mean we can't talk to them about certain things. That being said, there are also cases where, let's say, the hallucination is interfering so much that they can't hear what you're saying very well. Like if someone is hearing voices so consistently and so loudly that it's almost like we have another presenter talking over me at the same time, that would be hard for anyone to just get basic directions to the library.
But just to clarify,
yeah.
You did say that people who are using alcohol, if they're drunk, it's extremely difficult, borderline impossible to have a useful conversation, which is maybe different than someone who's hallucinating.
Oh, yeah.
Right?
So I think that's the other thing. So I wasn't sure if your question was talking about using substances in general or in the moment.
In the moment.
Yeah. I would say wait for the next day or wait until later in the day when someone's a little bit less intoxicated, because you'll probably save yourself and your loved one a lot of time and stress.
Here's one. Can we treat psychosis and substance use together, or is it best to work on them one at a time? I know you did address that in part, but maybe you could reiterate that, because it's kind of a super basic question about this whole topic.
Oh yeah, for sure. Thank you. So the best recommended practice is to have what's called an integrated treatment, where you are addressing the breadth of the concerns across psychosis and substance use, or it could be substance use and bipolar disorder, with or without psychosis. It's sort of whatever's on board, it's most helpful to do that together. The same approach goes if people are using more than one type of substance too, because if you treat one, sometimes people end up replacing it with another, and so you kind of end up feeling like you're back at square one. So treating both together would be recommended. I also realize that not everyone is up for that in terms of clinicians sometimes, their comfort level, or the clients themselves. And so it's okay to start with wherever you can start too. And so again, this goes back to, we don't need to put our agenda on other people necessarily. And also, yes, we can present them with what would likely be most helpful.
Can we talk for a second about being overwhelmed?
Yeah, sure.
Because this is a lot of what we deal with at NAMI, where we run these family support groups, and we have between 6 and 15 or sometimes even 20 people, and the stories we hear are so difficult that people are psychotic, using substances, maybe in and out of incarceration, maybe homeless, And people feel really overwhelmed and they feel like, I just don't know what to do. I don't even know where to start. And sometimes I feel like giving up.
Yeah.
And maybe this is an impossible question, but as a therapist, how do you get started on that?
I'm so glad you asked that. So I'd mentioned craft before, that we adapted for early psychosis, and I think it really could be relevant for so many families in all types of situations. In the original manual, they put self-care last. And I remember reading that and I was like, why is it all the way back here? And so for our sessions, we bring it in day one. And we talk about how important it is for family members to think about their own self-care and know it doesn't have to be just something comforting or fun. It can be hard yet important things that we do for ourselves too. Whether that's saying we're going to do something that's been weighing on us and we want to get that weight off, or it could be saying no to putting something on our plate. So we work on that by identifying what's important to people. So we ask people how happy they feel in different life areas and have them choose the priority area for them. Think about what it would look like for them to improve their happiness in that area, and then set a very specific goal every week on different things that help serve that individual family member. And when people are feeling overwhelmed, this does a couple of things. One, reorients people to what is in their sphere of influence. And two, it helps people see progress every week usually, even if they may not be seeing that much change around them. And seeing one's own progress is really reinforcing and empowering for the family member. And I think it helps do the general communication guideline that I talked about of keeping ourselves in the best place that we can, so that we put our best foot forward in as many conversations or interactions that we can.
Thank you for that. And that kind of leads me to a follow-up question. You know, the old saying, you can lead a horse to water, but you can't make them drink. So when patients show up for a therapy in an outpatient office, that right there is a sign of some initiative and is good news.
Oh, yeah.
And when patients or when family members come to our family support groups and just show up, we're happy to see them, even if they don't say anything.
Right.
We're happy to see them. It's the people who don't show up at all, and there's not much we can do about that. Do you have any advice about the people who just don't show up or won't show up, or they have a child? We recently had someone who told us in a family support group that their son was living in the bathtub and just wouldn't get out for days and weeks on end, and they couldn't get them out of the bathtub. Without water in it, mind you, but still, it was a bad situation. So what's your advice about those really intractable situations?
That's a toughie. I'm sorry that the family that you were referring to has had a loved one in that situation. We've definitely had different family members who have had loved ones who may be living in a car and won't come inside the house, or maybe, not wanting to be around the family at all, or maybe living in another house but not wanting to leave that house. So these things definitely do come up. In situations like this, I think back to the relationship bank idea and how we can preserve those open lines of communication with our loved ones so that we keep the opportunities available to be able to help them in different ways. So that is one. And then two, when we're having conversations with our loved ones, instead of thinking about how do I get them into treatment or into the door, one of the milestone conversations that we start with is having families ask, if they are not already abundantly clear on this, what is important to their loved one. For some people, it's, I want to feel safe, or if they're not feeling safe, or maybe it's, I don't want these people following me, that they think are following them. And so understanding what people want first can help think about anything that you may offer them later, linking it back to how it will help them get what they want. And some of the strategies there for introducing options for how to get what they want would be sampling. So not expecting any commitment, like, hey, if you're gonna live here, you gotta be doing therapy for the rest of your life. I mean, that's a big commitment. Even doing therapy for like a whole, month sometimes for people can feel like a lot, because I don't know about you, I mean, we're all different people. I'm probably not the best therapist for everyone, and not every therapist would be the best for me. So being able to say, hey, would you be up for trying to go to this meeting once or check it out for 15 minutes, see what you think. Kind of do the foot in the door approach could help. Another can be trying to very explicitly link how it might help them get closer to what they care about in a curious way, not like a you can guarantee it's going to happen way. And ask them what they think too. Sometimes it feels like we have to come up with all the answers.
How
We can
about
be collaborative.
How about the issue of treating people in their home or where they live, as opposed to having them come to your office, which can be itself daunting and difficult? We've had at NAMI folks from, I think it's called Open Dialogue, come speak to us, and they do the home-based therapy, and they have two people go in at the same time, and they listen, and then they reflect back to the family. What's your opinion about home-based or where the patient is living based therapy?
I think that can be so needed, especially in some of these cases where people are literally not leaving their door. If people are familiar with this idea of PACT or ACT, assertive community treatment, some of the PACT teams may also use open dialogue, some may not, but it's this type of approach where it's kind of similar to coordinated specialty care, except it will go to you, or you can do meetings in the community, whether it be at a library or a coffee shop, go to the grocery store with someone, or meet in their home. And so McLean has a PACT program. There are other PACT programs with limited availability, but availability through the Department of Mental Health in Massachusetts. And those teams could be particularly helpful in these types of cases. The other way that I think, fortunately, has become more accessible to people is to do online meetings. Of course, it is helpful to have eyes on a person the first time you're meeting them. And some people do have some paranoia about using technology, but for others, that's the only way they do feel comfortable meeting with folks. So whatever will help to meet the person where they're at, I think is worth discussing.
So that reminds me of another question that we've got here, which is about social media, and especially for younger people, which maybe is defined as, I don't know, under 50. How do you think social media has either helped or hurt people and families who have a loved one with mental illness?
So I think that it's actually been really helpful in a lot of instances. So for instance, back when I had started my training, I don't know if they either didn't exist so much or I wasn't aware of it, but there have been so many different groups, whether it's students with psychosis or different support groups on different social media platforms, where people are really able to find community and get support, dismantle some of the stigma that's been out there. I think it's really helped people find folks going through a very similar thing to themselves, whether that be the family member perspective or having the psychosis perspective, or sometimes those people are in the same forums. I've definitely seen some of those groups or conversations online, and I think it's been a way for people to ask questions that they may not feel comfortable asking their current treatment team or their family members, right? Like one of the slides that I showed earlier. So I think it's opened up access for people to educate themselves and to ask questions and also to find support. So I think that's been really helpful. I think people are much more likely now, not just for psychosis or substance use, to talk about their mental health journey or seeing a therapist. So I think that social media has been helpful in that way, normalizing this. And also it could be potentially difficult for people too. There's research suggesting that the more time people are spending on social media, and I don't think they're getting too nitty gritty in terms of the quality or type of social media, that can be associated with more depression or other mental health concerns. So I think there are pros and cons, and depending on the person, engaging with it in moderation or in a meaningful way can help or hinder the process.
Right, and just as an advertisement, we're going to have a whole session on AI and mental illness with
AI is a whole other
Dr.
thing,
John
yeah.
Torres from BIDMC coming up. So here's another question from the audience. How do we combat media influence saying that ketamine or LSD are curative?
Well, I think in talking about online information, we are inundated. We talk about being overwhelmed, just completely overwhelmed by all types of information everywhere. And sometimes we don't know who to trust. And so I think that in terms of the media, no, I personally am not in control of the media per se. However, we can think about, well, who's accessing that media? How can we be informed consumers or help the people in our lives be informed consumers? So trying to think about looking at trusted sources, whether that be evidence-based peer-reviewed articles that might be in scientific journals, or information that's coming from the National Institutes of Health or from places like NAMI. I think that can help, because there will inevitably be people saying all types of things online. And also, if you have ideas about information that you would want to get out there, that's also a chance to advocate for more information that you would like to share with people too. Because I think that there will be multiple sides to any conversation. And I think giving people the information available to them will help them make the best decisions.
Yeah, and I would add to your answer that, in my work as a hospice physician, we use both ketamine and LSD, believe it or not. And ketamine and LSD can be helpful to some people and really harmful to other people. So it's a very good question, and it's kind of a nuanced answer. This person asked, do you think that marijuana use or alcohol use is more likely to induce psychosis in young people? Or maybe use or abuse, either one?
I would say, based on the research that's out there right now, marijuana has a stronger association with a risk for psychosis than alcohol, and also alcohol can also have its own risk for psychosis too. So both are related, and both have different potential biological and other physical consequences. Marijuana is usually a bigger part of the conversation with psychosis.
Thank you. Here is a specific question. Are there resources for adult children of aging parents, and the parents may be experiencing psychosis in the setting of dementia and or late life depression? There's a second part to this question, but take the first part.
Okay, sure. So we have had a family member who had a parent that we did work with. So yeah, I mean, I think the experience is definitely different. And I think in the context of dementia, there are folks at McLean, at least, and probably elsewhere too, that have caregivers, support groups, or therapy options for people. So there's an outpatient group, for instance, that serves caregivers of people with dementia. It's not necessarily specific for people who have psychosis in that context, but it's not uncommon for people, at least who I've spoken with, who work in our geriatric psychiatry units, to say that their clients with dementia also do experience psychosis at times. So I think looking for those types of supports can be helpful, and there's definitely a lot of research going on about caregiver supports for loved ones who have aging parents with dementia. The second part of the question?
The second part of the question was, in the geriatric population, what substances are most often problematic?
Oh, good question. So I'm not necessarily an expert in geriatric psychiatry. However, from what I recall, from what I've read most recently, I think, well, certainly nicotine, alcohol, and cannabis. So they're the most commonly used substances in the country right now. And so it's no exception for people who are on the older end of their experience. I do think that there has been some information about what's changed and for whom with, let's say, the legalization of cannabis. People who are a bit older or like of the legal age to buy cannabis and older are perhaps more likely to use it more or have that increase because it's more accessible to them now. So that is something to think about. But I wouldn't say that there's a vastly necessarily different profile for people who are seeking geriatric services, but I'm not 100% sure.
Now, you mentioned nicotine, and just to get this one off the table, cigarettes and psychosis, is there any relationship or not really?
Yeah, so I think, so I used to be a nicotine researcher for a little while there as well. And so it's tough because sometimes clinicians who are treating psychosis don't give cigarette smoking a second thought. And in reality, there are many more people dying as a result of cigarette-related illnesses than schizophrenia in a given year. Back when I was a postdoc, I think it was over 400,000 people a year or so dying in the United States due to tobacco or nicotine-related illnesses. So I think that from a risk standpoint, no, it's not like cannabis necessarily, but yes, there have been some studies showing that there could be some relationship between the effects of cigarette smoking and psychosis, but the data are not necessarily as robust, certainly, as for cannabis, and there's just not as much data available, period, for things like nicotine vaping pouches or things like that, because it's relatively newer.
Yeah, I mean, in my experience, I was a consultant to the Massachusetts Mental Health Center for 5 years, and a lot of those patients smoked, and a high percentage of those patients got lung cancer compared with the general population. And there were so many things to worry about in that population. You're quite right, that the smoking was kind of, well, we can't really deal with that one.
But it's
and that was the one that ended up being lethal. Here's a kind of related question. If we look at the incarcerated population and we think about underlying mental illness and substance use, I know it's a high percentage, but what can you tell us about that relationship with incarceration?
So I have a colleague who would probably be able to better answer this than I would. I think that it's going to be the case, like, for instance, among people who have psychosis, there are going to be higher rates of substance use than the average population. Among those who are incarcerated, relative to the people who are not incarcerated, I wouldn't be surprised if there were also higher rates of substance use within that subset of the population. So I think that there is definitely a lot of work happening trying to improve services and the way we help treat and address substance use concerns in the context of mental health services in general in Massachusetts. And there's a wonderful doctor out in Western Mass, Ruth Potey, who does a lot of work trying to improve how these things go hand in hand in some of the justice settings out there. So yeah, it's a big problem, and also people are working on trying to improve it.
Great, thank you for that. Well, believe it or not, we're getting through all our questions, which is great. What is your opinion about the current training of trainees, both in psychology and psychiatry, for their understanding of the concepts that we've been talking about tonight?
Ooh, yeah. So I think just in the past week, I got an email asking if I could do my training seminar on craft, actually, for the Harvard Medical School Addiction Fellows. And so, of course, I said yes. And I'm not sure that they had gotten that training before I had started doing it a few years ago. And there are also different trainings that I've been a part of, or conferences that I've been a part of, trying to spread the word about these evidence-based approaches like CRAFT that have been around since the 1990s and are recommended by SAMHSA, the Substance Abuse and Mental Health Administration, to give to families. And a lot of people don't know that this exists. I didn't know that it existed when I was in grad school. So as part of my training, I feel like that was a gap at the time. And I know you can't learn everything all at once. I'm a lifelong learner. And also I think that, I guess, because of groups like this and things like social media and just a greater use of the internet in general, we are able to access more opportunities for training. So that means training for clinicians, but it also means training for family members too. I remember the first big CRAFT training that I had led with the person who helped create it, Bob Myers. There was a family member who was there who was not a clinician, and they were asking about what it would look like to kind of get some of their services started. And I think we're in such a great time where people can choose to get more training for themselves a lot of times. And also it's tough to get training if you don't know those opportunities exist. So I think that one of the things that I'm interested in and haven't had a chance to do fully yet is think about ways to talk to different graduate training programs or medical training programs to help people learn what the options are, so that even if they don't know or they don't want to take the time to learn X, Y, or Z technique, that they could at least know that resources exist about it and refer clients and family members to those resources appropriately.
Right, so to that point about, and we're coming down the home stretch here, to that point about services,
Yes.
I think you kindly offered to share your slides
Yes.
with folks that are interested. So we'll make those available. And if anyone out there is interested, you can email us at NAMI and we'll send them to you, and thank you for that offer. Are there any last questions from the audience tonight? Just raise your hand and yell it out. Okay. Yes, go ahead. Actually, hang on a second. I'm going to give you the mic. So, okay, yell. Okay, go ahead and yell.
Just to comment on what you were saying about family support, education, trying to include whatever way is possible to bring them into the treatment field. I graduated in 1998 with MSW at Smith, trained at BI for a few years, worked inpatient, and then worked at Cambridge Hospital in the psych emergency service, and then it closed, and I worked in the community, and now I'm back doing per diem work. And I was always, like, one of my biggest interests was serving systems and family systems. And so I trained at the Family Institute at Cambridge in family therapy for a year, and I was always really, interested in my own work and with the residents and training, like, families, you need to figure out how to help the person or take care of themselves. And I think it's really painful to say that I think there's less family work across the whole system of psychiatry. When I was at BI inpatient, we had great family workers, great conversations, longer lengths of stay, and then follow up. And there's everything that protects someone's privacy, but it really breaks down the whole effort of it.
So really the question is about the decline in the emphasis on the family?
Yeah,
Is that fair?
And what you're saying,
Right.
Julie, to bring CRAFT and other things back into psychiatry, psychology, medical residents, social work agents, and get them excited about it. Because it feels, it's like.
Can you comment on that?
Yeah, I think that's such a good point. And these are questions that I've asked people that I work with too. Like, hey, why isn't there as much family work? And people have shared similar stories that, yes, when there were longer lengths of stay on like the detox unit, for instance, there was more family involvement or work because people had more bandwidth to do so. So I think some of the larger systems at play, whether that be payers or length of stay, system issues, have limited some of their resources or opportunities for us to have those conversations. I think even when I had proposed initially starting a clinic for families, the initial reaction was, I don't know about that. Would families want to do that? How would this work? And we're doing time limited individual therapy. And so I think in some models where there's a loved one who's in treatment and you try to bring a family member in, some people aren't able to be reimbursed for any of those minutes or hours that you spend with families, which makes it less likely that they would take the time to do that. There are models now where there are certain service codes that people can use to bill for those services, but whether or not an institution or an insurance company has agreed to pay for those is another story. And so I think that there are lots of wonderful people trying to advocate for more of these services because they're needed. And I think, thankfully, the pendulum is swinging so that we're talking more about not just the person at the center of concern, who is hugely important, but also thinking about the ecological systems that exist, the family, the community, the larger government system organizations and the overall society, that all of these things are part of the solution.
Great. Well, I think that was an excellent last question. Oh, we have one more. Okay, excellent. Final last question. Say nice and loud.
Number one, when somebody's on an antipsychotic medication, does smoking weed reduce the effectiveness? I might have hit this right.
Ooh, I don't think we touched on this yet. So,
Or marijuana, whatever.
yeah, from like a pharmacokinetic standpoint, I'm not sure if I could answer your question fully. From a what's associated with what standpoint, yes, there is an association of using cannabis and lower medication adherence, or using the medication less. In terms of its effectiveness, I'm not 100% sure. There is some information about nicotine and certain substances where, depending on the level of nicotine that somebody is using, it will change the metabolism of the antipsychotic medication that they may be on. I'm not 100% sure which ones, I'm not going to say, but this is a real question. What's the interaction effect? Not just what is the effect on symptoms, but how does this affect or counter what we're trying to do in treatment for psychosis? So I will look into that more and I will see if I can find the answer.
Okay, so here's this problem.
Go ahead, nice and loud, so we can hear you.
You have an individual, schizophrenia, they're no longer, you're getting the LAI.
Long-acting injectable.
They insist on still smoking marijuana. In terms of harm reduction, would it be beneficial if, let's say, the family would say, okay, we're going to give you money to smoke marijuana, but it has to be a specific strain, like quality control. THC,
Like CBD.
I never smoked marijuana. I don't know the first thing about it in terms of going to dispensaries or any of that. But I do know there's been families in terms of even the person's on the LIIs. I mean, it does take the delusions down, but they're still a lot of times emotionally dysregulated. And the family basically gives them money to go get pot, partly to, I mean, they're doing, everybody's doing the best they can right here.
Yeah.
So the question is, in terms of, for that loved one, and again, I don't know if there's a clear answer, but these are things just to think of, to throw out there, whether they could, okay, this is the strain you would use, right? I don't know. I'm just throwing ideas out there. This is something I am about.
Any thoughts about that?
Yeah, so we have definitely had family members who have shared that they have given their loved ones funds to buy cannabis or have driven them to the dispensary sometimes, even though they have been concerned about that or feel compromised by doing that. So I think there's not necessarily just one answer. However, there are some considerations. One would be, what do you as a family member personally feel comfortable with? When we talk about our healthy boundaries or allowing for natural consequences discussion, we talk about how every family's boundaries are different. And at the end of the day, if there is a scenario where you feel like it's hard to sleep at night for you, or you feel like you're compromising your own values, that's an opportunity to say, hey, maybe I've identified a boundary for myself. How can I communicate that with my loved one? Because a boundary isn't saying, I don't accept your behavior. A boundary is, here's what I'm willing to do, and I'm going to share that expectation of myself with you. So that's one thing, how one feels about themselves. Two would be to say, okay, like let's say if it's a certain strain, the certain strain, I'm not 100% sure if there's, one strain off the top of my head, let's say, that would be something that would be less harmful than another, aside from something with a higher CBD content versus lower THC content. We have talked with families about how they could potentially reduce the amount of money that they give to go to the dispensary over time, or reduce the number of visits to the dispensary over time. And actually, for some folks who have tried that reduction strategy, even though their loved ones still continued to go to the dispensary and the family was still financing that, their loved one actually ended up reducing how much they wanted to go to the dispensary over time, and actually had a period of sobriety too. So some of those changes can really have positive effects.
Well, thank you for the question, and thank you all for showing up tonight, and thank you, Julie, for giving us really a lot to think about.
Thanks for having me.
We're definitely all in this together, whether we are a psychologist like you, or we're volunteers for NAMI, or we have a loved one in our family, or some combination of those things. I want to end on one of the concepts you shared with us, and this doesn't require an answer for you. It only requires appreciation from me, which is your phrase, relationship bank. I really like that. And I think that we're all always working on putting more into the relationship bank, because that makes everything go better. So thank you very much. And
Thank you.
with that, we are adjourned.